Hello, everyone. So, we are going live today and we are talking about Polycystic Ovarian Syndrome, which is commonly known as the PCOS. Myself, I am RJ Riddhi, and today I'm going to be talking to four brilliant doctors who are specialists in this field. Uh, Let me tell you that PCOS is a hormonal condition that actually affects women during reproductive years. And today, the experts from Manipal Hospital are going to talk about this condition that has been growing in large numbers around the world. So, first of all, I'd like to welcome the doctors. Welcome on board, doctors.
Thank you.
Thank you.
Let me start off with introducing all the doctors who are there today on the panel. First, I'd like to introduce Dr. Arunima Haldar. She's a consultant IVF and reproductive medicine, Manipal Hospitals, Whitefield, Bengaluru. And Dr. Haldar specializes in IVF, infertility, and reproductive endocrinology. Welcome on the panel today, doctor.
Thank you, Riddhi.
The next doctor we have is Dr. Geeta Veerappa Kumar. She's a consultant obstetrics, I'm sorry if I'm pronouncing this wrong though, and gynecology from Manipal Hospital, Varthu Road, Bengaluru. And Dr. Geeta specializes in managing high-risk pregnancies, infertility, hysterectomy, gynac infertility, and intrauterine insemination, which is IUI. Welcome, Dr. Kumar. The next doctor we have is Dr. Monica Sharma, who is a consultant diabetics and endocrinology, Manipal Hospital from Dwarka, Delhi. And Dr. Monica specializes in diabetes, thyroid, PCOD, pediatric endocrinology, obesity, and bone disorder. Welcome, Dr. Monica Sharma.
Thank you.
And the last doctor on the panel we have is Dr. Nabanita Saha. So Miss Namanita Saha is the Chief Clinical Dietitian, Manipal Hospital, Old Airport Road, Bengaluru, and she specializes in therapeutic diet planning for obesity, diabetes, cardiac, renal, PCOS, pediatric, and critically ill patients. Welcome, Dr. Namanita Saha.
Thank you, Riddhi.
So, doctors, today we're going to be touching upon a couple of questions and basically that speaks about PCOS. I will start with Dr. Geeta Veerappa Kumar. I'd first like to ask you, what is PCOS or PCOD? Doctor, your mic is off.
Yeah. Can you hear me now?
Yes, I can.
Yeah. Welcome everybody to this live broadcast and a very good afternoon to you all. So as Riddhi has rightly started with the question, what is PCOS or PCOD? We use the two terms interchangeably. So PCOS expands to Polycystic Ovarian Syndrome or Polycystic Ovarian Disease, as we use the terms interchangeably. So now when we're looking at a woman and we are diagnosing her as a PCOS, we're looking for three criteria. So the first one we look is whether they have irregular cycles. So it could be very short cycles within 21 days. It could be a long cycle, about 3 to 4 months apart. So when a person has irregular cycles, it means that they are not ovulating correctly. So it's a sign of anovulation. The second criteria that we're looking at is signs of hyperandrogenism, which basically means we are looking whether the person has signs of excess of male hormones in very simple terms. So now this we can either see in the patient clinically, somebody who's got excess acne, somebody whose scalp hair is thinning, they're losing hair, they've got hair in unwanted places like the upper lips, over the chin. Or at times we do the blood test. We look at the various hormones like the testosterone, the DHEA, and we find that they are raised. So this male hormone could either be clinically evident or we could do a laboratory test. And the final criteria that we look for is the ultrasound criteria. So when we're doing an ultrasound, we look at the ovaries, how they look, how big are they. So if any one of the ovaries is more than 10 cc in volume, that's the criteria for the normal ovary. And they appear polycystic, wherein they've got multiple small cysts. So when I say small cyst, I mean cysts which are less than 1 centimeter in size. Because we have a lot of patients who come up with, 4 centimeter, 5 centimeter. Is that PCOD? That is not PCOD. So we are looking at multiple, that is more than 12 cysts, which are less than 1 centimeter in size. So if any of the two criteria out of three is present in a patient, so we diagnose it as a polycystic ovarian syndrome.
All right. Thank you so much, Dr. Geeta. As in when you were speaking, someone who suffers from PCOS, I was just tick marking all the boxes. Do I have this?
Yeah.
Do I have this? Do I have this?
Yeah.
I
Fine.
want to ask you another question. Can it
Yeah.
affect the young girls, or is it at a particular age that it comes in?
No, I mean, PCOS now we're increasingly diagnosing it across all age groups, right from the postmenstrual up to the premenopausal age group. So studies say that about 5% of the women between the ages of 15 to 24 and about 4.8, which is almost close to 5% of the women from the age of 24 to 45 are diagnosed with PCOS in the present age. So almost everyone after the menstruation till the menopause can be diagnosed with a PCOS.
All right, thank you so much, Dr. Geeta. I'd like to move to Dr. Arunima, and I want to talk about the myth around PCOS. A lot of statements that I've heard which says PCOS means I have cyst in the ovaries. Can you tell us if it's a myth or it's true?
So this is a very common question, which a lot of girls they will come and ask the doctor, "Do I actually have cysts in the ovary?" They're like really scared what to do about the cysts. So let me just define, like Dr. Geeta very rightly told right now. So the target is less than 1 centimeter. So I'll just differentiate between cysts and follicles. So basically, cysts are any fluid-filled structure in the ovary which is more than 1 centimeter inside, and usually they may or may not be secreting a hormone. They may be something called as a simple cyst, basically clear kind of a cyst, or they may contain blood inside them, or they may be chocolate cysts. So these are all pathological cysts. One more thing about cysts is that usually they will maintain the size throughout the cycle. A follicle, on the other hand, is a small fluid filled structure which is actually containing the egg inside it. And this follicle will be actually growing throughout the cycle, and probably around the ovulation time it will rupture. So this is the difference between cysts and follicles. Now in PCOS, what happens, there is a continuous effort, of growing the follicles to the level where it reaches the uh, size, the desired size, and ruptures. But that does not happen in PCOS. So there are several attempts, monthly attempts of growing in this fashion. Ultimately, there is something called a stockpiling. So the small follicles, they get studded all around the ovaries, and it looks like many follicles are there. So probably PCOS polycystic is a misnomer. It should have been probably polyfollicular, but this is what it is. It is how it has been named. And so, but definitely people who are polycystic, they do not have any pathological cyst per se in the ovary. So that's a myth which a lot of
All
people
right.
have.
Thank you for clearing and clarifying that. I'm sure a lot of people might find relief in your answer. There's another myth around PCOS. Only overweight women get PCOS. A lot of people are like, I am thin. How can I get PCOS? So, can you tell us about that, please?
Yeah, it's true that a lot of overweight women get PCOS, but some thin women also may have PCOS. Basically, this is not related to your weight or your hyperinsulinemia, which we will eventually talk about. It is mainly related to the amount of one hormone called as luteinizing hormone, LH hormone, which is secreted from your brain. This hormone, this is predominantly LH hormone. The luteinizing hormone is secreted more than the FSH hormone, so there is an imbalance there, as a result of which you get the PCOS. This is something which could have been genetically predisposed, or it could have been something which would have happened. Some epigenetic modification would have happened in your mother's uterus when you were there in the uterus. So this is something which like the woman will not usually have any role in developing this kind of PCOS. Usually, they will be very depressed, saying that what did I do that I got PCOS? I'm not even obese. So such women should not feel depressed, because this is something which is not in their hand. It is probably from the time they have been birth. It has been programmed in that way. So yes, lean women can develop PCOS.
All right, that answers also a couple of doubts that is running in people's head. Moving on to Dr. Navanita Saha, since we were talking about weight, there is this question that I'd like to ask you: that does the diet for lean and obese PCOS differ?
Okay. So we all know obesity is a very common symptom in PCOS. And as Dr. Arindama also said that there are people who are lean and still have PCOS. So before telling the diet, which will whether it's differ for both, I want to tell what should be the diet for a PCOS woman, right? If she is suffering from PCOS. So, apart from obesity, there is other sign of PCOS, that is insulin resistance. Almost 70% of girls or women who are having PCOS suffering from insulin resistance. That means they have a lot of insulin in their body running, and it's not been utilized by the body cell. So. That is one thing. And apart from that, they also will have inflammation, chronic low grade inflammation. Um, so other than having, losing hairs and having hairs, facial hairs, and other acne and all that, so diet plays a very important role because you cannot just lose weight following a low calorie diet or just following a certain fat diet, because here you have to follow a diet which can balance your hormones, control your insulin levels, right? So for that, there are various diet which is available. Something you can go for a low GI diet, that is a low glycemic index diet, food which doesn't increase your sugar levels after you eat them, right? Especially like whole grains, cereals, pulses. Uh, so food at their most natural form you should include. Okay. Secondly, you also can have Mediterranean diet, which focus more on healthy fats like olive oil, fish, which contain omega-3, lots of fruits and vegetables in your diet, whole grains, cereals, right? So those kind of diet, again, there is something called DASH diet, that mainly for hypertension patient, that is dietary approach to stop hypertension, but that also a very healthy diet which focus mainly on fruits and vegetables and having less of salt, less of processed food, right? So one have to follow a low glycemic index diet, that is have more of whole grains, avoid any kind of processed food, refined products, sugary food, right, which are simple form of sugars. You can have more of fruits and vegetables. Secondly, have mindful eating. Maintain your portion size. So PCOS people will be having a lot of cravings because of their insulin resistance. They feel hungry frequently and crave for sugar. So when you follow proper diet, your cravings will come down. Secondly, include good amount of protein. Have lean protein. Include lean chicken. You can have fish, as I said. You can have eggs. Okay. Include legumes. You can have nuts. Okay. Healthy fats. Include healthy oils, oily seeds. All those you should have. Also focus on hydration. Good hydration. You should drink a lot of fluid. You should your body should able to remove all the toxins from your body, right? So you should flush out everything because there's all can cause inflammation, and PCOS women are prone to inflammation. So this is what you should follow. Also, apart from that, they should focus on certain nutrients like some vitamin D, omega-3, right, magnesium, iron, because they will be deficient on those nutrients. So make sure your vitamin D is always above 30. I have seen so many patients, the first thing I ask them to measure their vitamin D, and it will be always low. So that also related to infertility, overweight, right? All those problem will be there. Also, they can have certain herbs like spearmint tea, which there are a lot of studies which showed it's beneficial. If you are taking 2 cups of spearmint tea in a day, and it will help to with PCOS symptoms. So this is the kind of diet that one should follow. Okay, and of course, exercise should play an important role. Both go hand in hand. So, yeah, that's what. And yes, when it comes to lean and obese PCOS, diet-wise is almost similar. In obese PCOS, we need to ensure that there is some weight loss, because a 5 to 10% of weight loss definitely improve their symptoms. Wherein PCOS, lean PCOS, they don't have to go for weight loss, but they can maintain weight. So maybe we have to restrict little calories in obese PCOS, but in lean PCOS, we have to ensure that we maintain the weight and follow a healthy PCOS diet.
All right. So, doctor, one main thing that you mentioned, exercise. I need to do it. I will try and do it for sure. But, Dr. Navanita, I'd like to ask you another question: is how is our gut health related to PCOS, and how can one person improve the gut health?
Okay, so as I said, your gut, see, PCOS also says a high risk of inflammation, right? Most of the women will be having a low grade inflammation. Most of them, they are not even aware of it, right? And the more the inflammation is, this lead to more of insulin resistance, that lead to overweight, that again aggravate your PCOS symptoms, right? So when we talk about gut health, our gut, our digestive tract, it contains lot of bacteria, right? It called microbiomes, which is a mixture of good and harmful bacteria. In PCOS women, the gut is always have more harmful bacteria in compared to a healthy bacteria, right? There will be a dysbiosis. So what will happen in PCOS? We are also see something called leaky gut. Means when there will be more of harmful bacteria, they make, there will be a you can say, just in a simple word, there will be holes in the gut, right? Small holes where our food or any other substance can directly leak into our blood circulation, right? And can cause inflammation. So that is very common in PCOS women. So what we have to do is we have to ensure that our gut is healthy. For that, we have to ensure we have good healthy bacteria. How can we achieve that? Through diet, of course. We have to include certain food items which can support our gut microflora. Food in like having high fiber food, right? Which will help for it's like a food for these bacteria. So include high fiber food, like you can include whole grains, cereals, pulses, vegetables, right? Fruits, those which will go there and digest, and it will it will act as a food for this bacteria. So for normal women, the recommendation is around 25 gram of fiber per day. But for one with PCOS, the recommendation is increased to 30 to 35 grams. So one have to take more of this fiber-rich food in their diet. Secondly, you can include more of probiotics, that is food which already contain live cultures of bacteria, healthy bacteria. Like you can have yogurt or curd. You can include certain fermented food, right? Your idli dosas. You can have pickles. You can take kimchi, there's this fermented cabbage, right? So those kind of food also will help you to improve your gut function, right? So this is how and avoid any kind of food which you might be allergic to or having intolerance, that can lead to again a lot of inflammation in your gut and again lead to further leaky gut. So avoid those food if you are aware of anything, and focus on this kind of food.
All right. Thank you so much, Dr. Navneeta. Coming to Dr. Monica, I'd like to ask you that how long does one have to be on medication to see any sort of positive results?
So basically, PCOS is a very, as ma'am mentioned, that it is a very simple disease, but it is a very complicated pathogenesis. We still don't exactly know what the trigger is that causes PCOD, and why some obese women will develop PCOD and why some of them will never develop PCOD. So since we don't have an exact explanation as to why it happens, unfortunately, the therapy is also symptom based. So we don't exactly treat the cause of the PCOD. The cause is mostly treated holistically, as Dr. Navinita mentioned, via diet and exercise. But for symptom control and for reducing for resuming the menses, for reducing the hair growth on the face and the body. All these are practical things that the young girls really do need to take care of. So for that purpose, medications are needed. Now the duration for which the medication has to be given and the effect that it shows depends upon what the purpose of giving the medication is. Some patients who present primarily with a phenotype of PCOD that has only a reduced reduction in the menses without any increase in hair growth, normally they are treated with combined oral contraceptive pills or estrogen progesterone combination pills. These contain low doses of hormones that are natural body hormones that are not synthesized in the body, or they are synthesized in the body of a PCOD woman in unequal amounts. Normally, what we see in a PCOD woman is they have an increased estrogen effect and a reduced progesterone effect. So, the imbalance between these two, in addition to increasing the androgens, or which are the male hormones, this causes all the symptoms of PCOD. So, in case a patient is an ovulatory PCOD, that is, she is not ovulating properly, she is having irregular menses. In that case, they are treated with combined OCPs, and these can start having the positive effect right from the get go. From the first few cycles itself, the cycle regularizes. That is because the patient's own menses, the endogenous menstruation ceases, and what we give to the patient is a withdrawal bleed. That is, we give cyclical menstrual pills, and then we withdraw them, and that is called a withdrawal bleed. So the ovulation never resumes, but the patient does have a normal menstrual cycle. While the second treatment for the hair growth, it takes time. The effect can last anywhere between 4 to 6 months, and normally we ask the patient not to stop the medication for a longer time, almost 9 months to an year, before they see any positive effect on the hair growth. Now, why is that so? That is because the hair cycle differs. The hair cycle, that is the anagen phase on the face, it lasts for about 4 to 6 weeks. So any drug that is given to reduce the amount of hair on the body or on the face has to be given for at least 3 to 4 cycles, for anagen cycles, for it to show any positive effect. So normally we see a positive effect only after 4 to 6 months of regularly taking the medications. So even in the beginning, when we start prescribing the medication for PCOD, it is very essential that you let the patient know that the menses will resume within the next 1 2 months. But if they are taking it primarily for the purpose of hair growth reduction, it takes time, because the cycle of hair lasts that long. So any medication given will take minimum 6 to 8 months of time for it to show any positive effect.
All right. Another thing which we commonly see is the fear, especially with pregnancy, right? So, what are the ways pregnancy can get complicated if one has PCOS?
So there are two kinds of. One is that there is a difficulty getting pregnant in patients with PCOD. Obviously, since the ovulation itself is impacted, they are not ovulating normally or not ovulating at regular intervals. So there is an infertility aspect related to it, and this is known as it can be either primary infertility or secondary. That is, it can happen at the get go, or it can happen even if the patient has conceived normally previously, since PCOD we know does not have any age of onset. So these patients do have a difficulty in conceiving naturally. The thing that helps in non-natural conception is what Dr. Navita has said, that a good diet with at least a 5 to 10% weight loss, it really helps in conceiving naturally. If even after doing all that the patient is not able to, then there are certain drugs which have a very low side effect profile, which can be used. There are letrozole, there is clomiphene citrate. All of them induce ovulation naturally in a PCOD patients. And in case that is not working, then we have a low growth gonadotropin therapy. Or in case that doesn't work, then obviously the patient can obviously go for an IUI or an IVF normally. But I would like to allay the fear that normally what we see in our practice is the natural conception rate of PCOD patients are more than 90%. So they need not worry that it's not such a big thing. But yes, there is a difficulty in conception. Coming to a pregnancy complications, since patients having PCOD are obese, Most patients are obese. These patients have a high risk to develop gestational diabetes of pregnancy. So that is one thing that they should be careful about. So that's why we do regular testing for gestational diabetes of pregnancy at the beginning when the patient is conceiving, and then again at 16 and 24 weeks, so that it can be taken care of at the get go.
All right, thank you, Dr. Monica. I mean, since we were talking about pregnancy, I'd like to come back to Dr. Arunima. And the thing that I'd like to ask you is what are the treatments that are available? Is IVF the only option?
No, it's not that IVF is like the only option. Dr. Monica already mentioned quite a bit about it. So we have basically two types of patients. One is the ovulating kind of PCOS, and one is the patient who is not ovulating. Now, the patient who is not ovulating, our job is to make her ovulate. So the treatment which we give here is ovulation induction. So we do it with certain medications, which are, they trigger the ovulation, which can be anything from letrozole or clomiphene. Along with that, we may or may not add something called as metformin. Okay, so this being said, we can try it for some 3 4 cycles. If this has not working out, then we can probably take the next step, which is going ahead and doing intrauterine insemination. Now we have to be also wary about the fact that there could be other factors playing in the infertility as well, like the patient may have a tubal blockage, or she may also have an associated uterine problem, or there could be semen problems in the husband. So we have to take care that we have seen all these things as well when we are not just going ahead and giving ovulation induction to these patients. That is one thing to look into. Now, there is a typical problem which we see in while treating these patients, especially when we are doing ovulation induction, or what we call as ovarian stimulation, where we want 2 or 3 follicles instead of one. So the typical problem is that they have something called as a very narrow window. So, which means that, say, for example, I want to give her an injection to get her ovulation happening. Now, the dose of injection is 75 international units. So, when I give 75 international units, nothing happens. Her ovaries are completely, stagnant. But when I make it double, the next dose is 150. So when I make it double, there is an explosive response. So this is the typical problem which we see in a lot of PCOS patients. So IVF, when we do IVF, the question is that if this kind of problem comes up, if we are repeatedly seeing with whatever we are trying, we are not able to get to 1 2 or max 3 follicles, we are getting an explosive response, then is the one time we want to do a IVF for this kind of patient. If we have tried several cycles of natural trying, which we have tried, IUIs for these patients, and nothing has worked out, we don't know what is the cause, but we know that there is an inherent PCOS problem. That is when again we want to go ahead with IVF. Or else there is some other factor playing as well, that we know that there is a tubal abnormality which could be a problem, or there is some male factor which could be corresponding along with the PCOS, it is adding to it. So in these situations, we would want to go ahead with an IVF. Not routinely. First step always will be to go ahead and give them a ovulation.
All right, that makes sense, Doctor. Thank you so much. Coming to Dr. Geeta. Now, PCOS can happen anytime. So,
Yes.
how to treat PCOS in teenagers, in reproductive age, and in premenopausal age?
Yeah, Riddhi. As you know, all the doctors have already talked about, since we don't know what is causing the PCOS, it's difficult to treat the cause of the PCOS. So, our management at all age groups is basically we are looking to manage the symptoms with which they are presenting. And as we've already talked, as Dr. Arunima rightly mentioned, there can be a lot of anxiety and depression in these patients. So you have to look at the patient as a whole. They need both. The most important support they need is a psychological support to allay their anxiety and fear regarding the PCOD. That is the foremost thing, because and also to remove the myth that any one treatment is going to completely cure them or get rid of PCOD for the lifetime. We get a lot of patients who have visited a lot of other doctors and they're being told, okay, you take the medications for 3 months, you'll be completely all right. And that when it doesn't happen, that leads to more anxiety, and more of depression in these patients. So we have to tell them there is nothing like a lifelong cure for PCO. So as long as we are managing the symptoms, we manage, as she said, when infertility patient, our goal is to get them pregnant. And once they have delivered, the symptoms of irregular cycles can come back. So it is first to reassure them there's nothing like a lifelong cure for the PCOD. We are going to manage with whatever problems you're presenting at what particular time that you're seeing us. So looking at the various age groups, now as the doctors have mentioned, the cornerstone management is the weight management, as many of the PCO, as rightly said, are obese. So the management of obesity remains the first focus for the treatment of these people with PCO, because what we have seen is even about a 5% reduction in their weight will lead to a large extent, it will help in regularizing the cycles even without medication. So even if they manage to lose about 5 to 10%, the cycles will go back to a normal pattern. It will also reduce the various other risk factors that we associate with PCOD, like diabetes, their cardiac risk factors, and of course, it's going to improve their own feelings of anxiety, depression, their own body image issues. So it's a big help. The first thing is to look at the weight management. Now, in the teenagers, usually the most common thing is irregular cycles and the unwanted hair and the acne. That's what the teenagers usually present to us with. Now, coming to the irregular cycles, now typically, do we need to bleed every month? Again, that's a myth. From a health point of view, a cycle once in 2 to 3 months is fine as far as the uterine health is concerned. Now, why 2 to 3 months? We don't want to leave beyond that because the lining of the uterus then tends to build up. That's what we call it as endometrial hyperplasia, and that can lead to further complications. So we want the women to bleed at least once in 2 to 3 months. Now, this can be achieved, in two, three ways. The first, as we talked about, is the weight management. A good loss of weight might itself help to regularize the cycles. And when we look at the medications, the common medications we use are either the contraceptive pills. So in people who do not have any contraindications, in whom we can safely use them, for now there are some people who have got a history of clot in the legs or lungs, they have had jaundice, they have migraines. In these people, we cannot use the contraceptive pills, but somebody in whom they can be safely used. Contraceptive pills are a very good method to keep the cycles regular and on time, because as Dr. Monica rightly said, the body seizes, it's the external hormones that we are giving that takes over and keeps the cycles regular. If they don't want contraceptive pills, another method we use is progesterones, just one half of the contraceptive pills. So that in fact avoids the side effects due to the estrogen. So the main hormonal side effect that we see is due to the estrogen component. So we just use progesterones for, let's say, about a week or so, once in 2 to 3 months, to make sure that the woman bleeds. So this is where the irregular cycles, this is how we manage the irregular cycles. Now, coming to the unwanted hair, of course, the contraceptive pills also help. And as Dr. Monica said, it takes about 4 to 6 months of the pills. We have got special pills which we use for the PCOD, where in the second half, so a contraceptive pill has got an estrogen and a progesterone component. That can be the first line of management. If we do not see any results with the conventional contraceptive pills, we also use some other kind of pills which have got anti-androgens, that is the anti-male hormone. There are different things like cyproterone acetate, which is added along with the estrogen, which also gives very good results in the treatment of acne and the hirsutism. So maybe a 6 to 9 month course of these pills will help to reduce the hair growth. The other way they can look at is to go for the cosmetic, the laser hair removal or the electrolysis, which is quite common these days. And as Dr. Arunima mentioned, there's another drug, metformin, which is actually an anti-diabetic drug, which helps to balance the hormones in the PCOS and can also help in these particular situations. Finally, we are also looking at infertility, which is the main the problem in the reproductive age group, and that Dr. Arunima has dealt it in detail, how we can, get these women to ovulate and help them to conceive. And in the perimenopause age group, it's always the problem of the irregular cycles more often, and as I've already mentioned. So in all this, we also have to remember that PCOD is associated with other risk factors like diabetes and the other cardiometabolic disorders, the cardiac. So the overall life stage, and to encourage them to adapt a healthy lifestyle will remain the cornerstone of management for these people.
All right. Thank you, Dr. Geeta. I'd like to move to Dr. Monica right now. And I want to ask you, can anybody start a laser therapy for hair growth in PCOS? And is it going to be less effective in reducing hair growth?
Laser therapy is one of the cornerstone of therapy for hair reduction that we use in PCOD. But unfortunately, in case of PCOD patients, it's generally not as effective till your hormones, that the underlying hormonal dysfunction is controlled. So normally, what we advise is that the patient need to be on a good hormonal therapy. It can be an androgen, it can be a this estrogen progesterone pill, it can be a progesterone pill. They need to be on some medication for at least 3 to 4 months before they start undergoing the laser sessions. See, laser therapy destroys the hair, and it destroys the hair follicle either by a concentrated beam of light, like for the laser, or for electrolysis, electric current is passed through that destroys the hair follicle. Now, this helps in reducing the amount of hair growth and reducing the rate of hair growth. Ultimately, with the destruction of the follicles because of the repeated sessions, there is reduction in the hair growth. The important thing to know is it is reduction in hair growth, it is removal. So it does not completely go away, but it reduces. So that's how there is a reduction in the hair growth. But for that, underlying hormonal therapies need to be taken regularly for a couple of months at least before initiating your laser sessions, because until the underlying hormones are controlled, what happens is that even if you do take the laser, the hair just comes back because the male hormones that are circulating in the body of a PCOD woman, they promote more terminal hair growth, that is thick dark hair growth. They promote these hair growths, so the laser therapy will ultimately not be very effective. If you do it, it won't be long lasting if you do it without controlling your hormone levels first.
All right, makes sense, Dr. Monica. Coming to Dr. Navneeta Saha, and this is my favorite question that I'd like to ask you, is does one need to avoid gluten and dairy in PCOS? And if they have to, would there be any alternatives for it?
Okay. So this is very controversial questions. Like many people ask me. Of course, those who are sensitive to gluten or dairy or it is lactose, they definitely have to avoid it if somebody is having celiac disease, for example, or if you have non-celiac gluten sensitivity or gluten intolerance, right? You don't have to be celiac always, but there could be a sensitive to gluten. In that case, of course, avoiding gluten will reduce your symptoms. And what happened in PCOS is there will be, as I said earlier, also there will be inflammation, right? And it's a metabolic disorder, and it will trigger a lot of other no, sensitivity. The patient will become sensitive to a lot of things, and they are not aware of it. Sometimes there will be intolerance to lactose or say dairy or to gluten or wheat products, and they're not aware. So what I ask them, if you have not checked it your intolerance, you can avoid it for certain period of time, say example 3 4 weeks to 6 weeks, and see how it helps you. Are your symptoms are coming down? If you are feeling fine, there is no change, then gradually you can again start taking it. But if your symptoms, example like you bloating or rushing to toilet immediately after having food, all those are coming down and you're feeling better, your energy levels have improved, it could be a sign that you are intolerant to gluten or dairy products. Also, so, if you are sensitive, then there are other alternatives. You can go for gluten-free cereals. Millets are very good examples. All the millets are gluten-free. That include your foxtail millet, ragi, jowar, bajra, barnyard millets, right? Quinoa, rice. You can go for brown rice or red rice, right? Depending on what you prefer. So those are the healthier options that you can go for. Coming to dairy, there are a lot of studies which says that there is a direct link of acne with including more of dairy products, right? So if you leave them for a certain period of time and if your acne are reducing, right? And you feel better. Again, bloating and all are not there. There could be a sign that you are intolerant to dairy product. So also in milk, there is a hormone called IGF-1, right? It's called insulin like growth factor, and it mimics insulin. So what will happen if you're taking more of dairy and having this particular hormone? Your ovaries will secrete more of testosterone. Okay, because there will be a lot of insulin running in your blood, and it leads to insulin resistance, and your body producing, ovaries producing more male hormones, and aggravate your PCOS. Also, if you are, say, example, there are many studies saying in dairy also, if you're taking, well, which one better, low fat or high fat, right? Full fat. So taking many of us will prefer taking low fat dairy products, right? Toned milk, low fat curd, fat free cheese, right? So it says that low fat dairy have a relation of producing more androgen. It increases your androgen levels. Okay, it aggravate your PCOS as compared to high fat dairy products. So if you have to choose dairy, I'll suggest first preferably go for full fat dairy products if you cannot eliminate dairy completely, because it also have good source of calcium, vitamin D, phosphorus, right? All other nutrients are there. Also choosing other dairy products like cheese, yogurt, which won't show or increase your androgen levels, are a good options for you. Again, there's something called A1 and A2 casein protein, right? That comes in the milk. So there's a lot of saying going on that A2 milk is better, right? Because it's this local cows, just the desi cow's milk. So A2 milk is a preferable options compared to A1, which will be increasing your inflammation. So my say is go for full fat A2 organic milk and dairy products. Limit it to 1 cup of milk per day. You can include cheese, paneer, yogurt. Preferably a full fat Greek yogurt will be a healthier option. If you don't want to go dairy free completely, because of, say, example of you want to reduce your acne, right? You have lactose intolerance or other problem, then you can have other alternatives, like you can go for almond milk, you can have coconut milk, oats milk, uh, all those other options are available, soy milk, this all you can have it. So yeah, so this again goes case to case. You need to first understand whether you are sensitive to it, whether you have any intolerance, and if it is, you can eliminate for some time to see if your symptoms improve, and then if it doesn't have any effect on you, then you gradually bring them back to your diet.
Thank you so much for throwing some light on that and giving us a little bit of clarity on what to eat, what not eat. And coming back to Dr. Geeta, is PCOS associated with any other condition? Like, is it inheritable?
Yeah, a clear, when you talk about inheritance, it is like whether from the mother, definitely will the daughter have it too. So, yes, it has been seen in the families, that the irregular cycles in the PCOS runs, but I think a clear genetic pattern of, this is how it runs hasn't been identified. And whether it is associated with other disorders, PCOD is a part of what we call the metabolic syndrome, wherein we have the obesity, and which is a part of the PCOD, the other metabolic disorders like hypertension, the cardiac risk, the diabetes, they all come under the umbrella of the metabolic syndrome, and the PCOD is a part of it. That is why when we are trying to manage the PCOD patients, the goal is not only to make the cycles regular or to make them conceive. You look at it an entire holistic way so that they reduce the weight, so that it reduces the risk for all these. No, another important association with PCOD is when they do not have cycles for a very long time, as Dr. Monica had mentioned, they have an excess of estrogen in their body. So this promotes the buildup of the endometrial lining, which also increases risk of endometrial carcinoma in these particular patients. So it is. So PCO is just not about managing the cycles or making them conceive. It is associated with a lot of other medical disorders, and we have to look at these patients in view of all these things that they are prone to, and advise and manage them accordingly.
All right. Thank you, Dr. Geeta. Dr. Arunima, the question I'd like to ask you is we spoke about difficulties in conceiving in some of the patients, right? What are the tests that may be needed to that the PCOS patient have to do before they plan on conceiving?
Okay, so basically, from the fertility point of view, apart from all the fertility related tests which we do, there are certain specific tests which we do in relation to PCOS. One is the FSH and the LH, which is done on the day two. FSH is follicular stimulating hormone, and LH is the luteinizing hormone. This, along with estrogen, is done on the second day of the period. So, why are we doing this test? We are trying to see how severe is the PCOS by looking at the LH FSH ratio. So that is one thing. The other thing, which probably is not given in the guidelines, but lot of infertility specialists will be wanting to do it, is called something called as the AMH, or the anti-Mullerian hormone. This hormone typically tells us what is the current reserve of eggs in the ovary. So in PCOS, we expect it to be really high. Now, if it is really high, say the normal range is approximately up to 3.5, 2 to 3.5 is what we call as the normal range. Now, if it is beyond that, it comes in the PCOS range. If it is beyond 3.5, that is. If it is really high, say 7, 8, 10, we understand that the PCOS is going to be very difficult to treat. In that situation, we know how much to titrate the drug, how low to start the drug with. As I said, that we have something called as a very narrow window in PCOS. So it's very important that we do this particular test. Apart from this, a regular scan of transvaginal sonography is something which is very important in this situation to understand how how severe the PCOS has gone, with whether the something called as the ovarian stromal thickness has increased a lot or not. Do we require eventually, if possible, we may require a surgery for these patients, to make them ovulate. That is not routinely prescribed, but do we need that? That is something which we have to decide. So these are the tests which we usually do from the fertility point of view, apart from the normal fertility tests when we are looking at a PCOS patient.
All right. Thank you, Dr. Arunima. I'd like to talk to Dr. Monica right now, and I'd like to ask her, is there a natural way to manage PCOS?
I think Dr. Namanita has already discussed quite a lot about this. The most
Right.
natural way to manage PCOD will be to attain and maintain a 5 to 10% weight loss. That has been shown consistently to reduce your circulating insulin level. Now, insulin we know has been involved in the pathogenesis of PCOD. These patients are not diabetic per se, they do have an increased risk of future development of diabetes, but they're not diabetics. What they do have is an impaired glucose tolerance or an impaired fasting glucose. Along with, they have an increased insulin levels. So these insulin levels, they act on the ovary, they act also centrally on the what we call as the hypothalamus and the pituitary, and they lead to the metabolic, they have been linked to the metabolic disturbance that leads to PCOD. So that's why when some PCOD patients, when they manage to and maintain the weight loss of up to 10%, they can even manage to eliminate their need for medication of PCOD. They can resume their normal menses, possibly because of the lowering of the insulin levels, which has a direct effect both centrally as well as peripherally, that is both on the brain as well as on the ovaries itself. So that reduces the, might have any effect that we're not completely aware of as yet, that how it reduces the androgen secretion. It also resumes the disordered LHFSH pulses that are present in the brain of a PCOD patient. So that's how we can manage PCOD by a natural way. Rest all, some patients do well with gluten-free diet, some patients do well with lactose-free diet. This is all as per the patient, what the patient, the diet suits the patient. As of now, what we recommend is a diet filled with complex carbohydrates, low fat diet without any trans fat, and without any fast foods, that is maida, soft drink, cold drink, all that should be avoided. That is all. Otherwise, on this diet, if the patient can maintain and reduce up 10% of weight loss with an increased physical activity, then that is perfect. Now, how much physical activity is required in PCOD? Normally, for diabetics, what we recommend is around 30 minutes per day. For PCOD, it's around 45 minutes per day of moderate intensity physical activity. A moderate intensity physical activity is something that raises your heart rate. So you should be a little bit out of breath and you should have a difficulty in talking normally if you are exercising at a moderate intensity. So that is what we recommend, around 5 days a week, at least a 45 minutes regular physical activity can lead to a sustained weight loss. But it is to be noted that the sustained weight loss begins only after about a 3 month mark of regular physical activity. So the patient have to maintain and motivate themselves at least for the first 3 months before they start to see any results.
Thank you, Dr. Monica. And before we go into questions from the public, this is the last question I'd like to ask Dr. Navanita. And the question is how to deal with PCOS related depression with diet and nutrition.
Okay, depression and anxiety is very common in PCOS. If anybody already suffering from PCOS, they will be knowing that in their lifetime they felt a severe mood swings, right? Sometimes they feel like crying off without any reason, or they'll have they get angry, on just suddenly they feel. All those kind of change in their temper. So and also there's so many studies which shows that PCOS women will have six-fold of chances of having depression or suffering from mental health. And as we all know, PCOS is related to insulin resistance, and which will lead to high androgen levels, and which give you all the symptoms of obesity, having acne, having facial hair, infertility. So you can understand a teenage or a young woman having all those symptoms where she cannot lose weight, even she is eating very small quantity, right? And she is trying to conceive where other all her friends are having children. So this all factors are enough to have depression. And most of the time they will not be so open, because as also in lean PCOS, as I said, you cannot make out they are having PCOS, right? So they are not very open to people, or they don't have those support system. So this all cause a lot of anxiety, depression among them. And the right way to manage it is to have talk to your doctors, talk to your nutritionist, ask for support, right? Follow a good healthy PCOS diet, as I have explained. Follow more of complex carb, have food at their natural best, avoid packet food as much possible, processed food as much, include good fats, healthy fats like fatty fish like salmon, tuna, mackerel, sardines, right? Include healthy oils, like you can include olive oil, cold pressed coconut oil, canola oil. Those all you can have, even a little bit of ghee also. So have those oil. Avoid deep fried food, food which contain trans fat, right? Reheating of oil, avoid all that. Include more of fruits and vegetables, which we miss it. I don't know how many of us will eat fruits on a daily basis, right? So include one or two fruits on a daily basis. Include you get all your nutrients, vitamins, and minerals, which they will be deficient of. Make sure you expose yourself to sunlight, at least 20 minutes of sunlight. If not, ensure that you take vitamin D supplement. So having some certain supplement like vitamin D, if you are vegetarian, not eating enough or no food which are rich in omega 3, you should include omega 3 supplements, right? Even for vegetarian, you can include walnuts, right? Flax seeds, which are good source of omega 3. Include healthy nuts, oily seeds, include more good proteins, right? So as I said, follow a healthy PCOS diet exercise regularly, take your supplement in the form of vitamin D, omega-3, myo-inositol, which is a vitamin B complex. This all shows to improve your symptoms, including your depression and anxiety.
All right, thank you so much, doctors. I'd like to now ask you the questions sent by the public. I'll start off with Dr. Arunima. There's a person who says that my periods are regular. How can I have PCOS?
Okay, so there is a possibility that when you have regular periods, you may have PCOS. See, PCOS may have various what we call as phenotypes. Phenotypes means the outward look of PCOS may be different for different people. Some people there were three symptoms which Dr. Geeta had mentioned. One was anovulation, that is not developing any follicle. The second one was hyperandrogenism, that is abnormal hair in the body. And third was ultrasound related features. Now, you may have something called as an ovulatory PCOS, where you have just the hyperandrogenism and the ultrasound features. So that is one possibility. The other thing is that some anovulatory PCOS may also bleed fairly regularly, probably because of something called as estrogen withdrawal. So that is a possibility, rare possibility, but most of the time these kind of patients are ovulatory PCOS. So that's a good thing in a way, because from my point of view, from the fertility point of view, because in spite of the fact that you have PCOS, you are ovulating. So that's good for me.
All right. Thank you so much, doctor. The next question is for Dr. Geeta. And the
Yeah.
person asks, what are the age group that PCOS is seen in?
Yes, I already mentioned,
Yeah, I know.
PCOS, we see it across the spectrum, right?
Right.
From the postmenarchal age group till the perimenopausal. So we have teenagers coming in with these, common problems of acne, hirsutism, irregular cycles. We have got women in their childbearing age coming with the problem of infertility. Then we later see people again, in the 40s coming again with irregular cycles and obesity. So there's no particular age group. It can be seen in all the women after their menarchal age.
All right. I hope that answers your question. The next one is for Dr. Nabanita. I think you have spoken a little bit about it, but just for this person, what are low GI carbs that people can consume?
Okay, so low GI food which have GI less than 69, normally those are moderate, and less than 50 comes are low GI. Those food which will, after taking, will not shoot up your sugar levels. So all your complex carbs, example, your millets, your whole grains, your brown rice, whole pulses, right? Fruits, vegetables, this all come under this. But a high GI food, if I want to tell you, is where is a processed food. Say, example, your white bread, right? Your maida products, then your fruit juices or cold drinks, sweet, sugar, any kind of bakery product. This all comes under high GI food and need to be avoided, because this will shoot up your sugar levels. This increase your insulin levels in your body, and then as your insulin resistance, all it will aggravate your PCOS symptoms.
Right. Thank you, Dr. Navanita. And the last question, actually, the second last question, I'd like to ask is Dr. Monica, what are the long-term side effects of hormonal pills?
So these hormonal pills that are given, they basically have two components. They have an estrogenic component and a progesterone component. So major side effects are from the estrogen component, and regular bleeding is induced by the progesterone component. So as such, the long-term side effects have not been studied in PCOD patients, but we did have a study in post-menopausal patients that was done in the 2000s. That was done to see what the effect of hormonal replacement therapy for patients was who were already had attained menopause. So these similar kind of pills were used for hormonal replacement therapy as well, and therein we found that there was a borderline rise in certain parameters of the metabolic kind. So there was an increased risk of dyslipidemia or cholesterol that might increased, borderline increased risk in the ovarian cancer. There was also an increased risk of dementia. But I want to emphasize that this was done in patients who were above 60 years of age, and they already had some of these, some of these disorders at baseline. So there's no clear cut, but based on these studies, what we do is that we do not give these hormonal pills continuously to any patient of PCOD. We normally have a gap period. So normally, if the patient does require these hormonal pills, and then if they do not menstruate at all without them, then what we give is we give a regular treatment for these patients to induce regular cycles for around 1 year, and after that we give a gap for around 3 to 6 months, where we see whether they have resumed their normal cycles or not. And after that, if they have resumed, we want to keep them off the pills. It's important to realize that these pills are only for symptom management, and they do not specifically have any role on the etiopathogenesis of PCOD. So we only give them on the need basis. So if it is needed, only then we give it. If the patient is menstruating normally without the need of these pills, then obviously we will not like to give it. So as such, there are certain minor side effects like nausea, vomiting, deranged liver profile that is managed within the OPD itself, and rarely it has leads to anything very severe.
All right. Thank you so much, Dr. Monica. Now, this is a question I'd like to put it out open to all, anybody who'd like to take it up and answer. There's a person who says, "Hi, ma'am. I was just 38 kgs and was diagnosed as lean PCOS and increased weight to 45. What would you like to tell?"
I'll I would like to know the BMI of that patient. That what she was she underweight before, and now has she become normal weight on the medications, or has she tried to gain weight because of the PCOD diagnosis? Because if she was underweight, then even an underweight patient can have something called as hypothalamic amenorrhea, and they may not menstruate normally if they are very underweight, because there is a hormone that is secreted by our fat cells called leptin that permits normal menses. So the PCOD diagnosis itself might need an update now that the patient is of normal weight. Just based on weight, that is all I think we can all say.
All right. I hope that answers all your questions. I would like to thank all the doctors on the panel today for coming out and speaking to us about PCOS, throwing a lot of light, and hoping that we all have a healthy lifestyle from here. I definitely have made lots of mental notes, a lot of things that I don't have to do, which you guys have mentioned. But thank you so much for the FAQ sessions with the doctor. Thank you to Dr. Namnita Saha, Dr. Geeta Kumar, Dr. Arunima, Dr. Monica Sharma, and all the listeners who have joined in this session, which is truly, truly helpful for everyone. Thank you, Doctor.
Thank you
Thank you.
so
Thank
much.
you so much.
Thank
Thanks a
you.
lot.
Thank you so much.